Good evening, everyone. Today I want to talk about something deceptively simple but critically important as we age: leg strength, particularly after 60. Now, this isn't about looking better or walking faster, though those are nice side effects. This is about maintaining independence, metabolic health, and extending health span, the number of years you can live well, not just long. Leg strength is one of the most robust indicators of longevity. That's not hyperbole, that's what the data show. A decline in leg power correlates strongly with increased fall risk, loss of mobility, and ultimately institutionalization. So the question is, what can we do right now to preserve or even improve lower body strength? We're going to discuss 3 vitamins, but I want to be clear, no supplement replaces strength training, proper protein intake, or movement. However, these vitamins play essential supporting roles in the biochemical processes that drive muscle health, neuromuscular coordination, and bone strength. Let's dive in. When we talk about optimizing leg strength in individuals over 60, the conversation often starts with protein intake, resistance training, and sometimes even hormone replacement therapy. But surprisingly, one of the most influential and underappreciated players in this equation is a molecule that many people still regard as a vitamin, despite functioning more like a hormone in the body: vitamin D. Now, when I say vitamin D is essential for musculoskeletal health, I don't mean it in a vague, generalized wellness sense. I mean this in a deeply biochemical and physiologically critical way. Without sufficient levels of active vitamin D, several systems that support skeletal integrity and muscular function begin to malfunction, subtly at first, but with increasingly visible clinical consequences over time. Let's begin with the basics, but then go deeper. Vitamin D, or more specifically its active form, 1025-dihydroxyvitamin D, also known as calcitriol, plays a central role in regulating calcium and phosphate metabolism, which are foundational for bone health. This is well known. What's less often discussed is that vitamin D receptors, VDRs, are present in skeletal muscle cells, and that vitamin D directly influences muscle protein synthesis, mitochondrial function, and even muscle fiber composition. This has profound implications for maintaining or recovering leg strength, particularly in older adults. Let's unpack that more deliberately. In young, healthy individuals, muscle strength is maintained through a dynamic balance of muscle protein synthesis and breakdown, neuromuscular coordination, and proper nutrient delivery. As we age, all of these systems become more fragile. An older adult doesn't just experience weaker muscles, they experience a decline in type 2 fast-twitch fibers, reduced muscle regeneration due to satellite cell dysfunction, and a higher baseline level of inflammaging, chronic low-grade inflammation that interferes with recovery and repair. Vitamin D, through its regulatory role in calcium transport, inflammatory cytokine expression, and even testosterone modulation, interfaces with all of these domains. Now, to move from mechanism to data, numerous observational studies have linked low serum levels of vitamin D, particularly serum 25-hydroxyvitamin D, 25-OHD, with poorer muscle strength and reduced physical performance in older adults. One large study published in the Journal of Clinical Endocrinology and Metabolism found that adults over the age of 60 with serum 25-OHD levels below 20 Nengencell had significantly lower grip strength and walking speed compared to those with levels in the 40-60 Nengencell range. While correlation doesn't equal causation, the biological plausibility here is strong. More compelling, though, is the interventional data: what happens when you correct a deficiency. A 2013 meta-analysis in the British Medical Journal analyzed 26 randomized controlled trials involving over 45,000 participants and concluded that vitamin D supplementation reduced the risk of falls in older adults by 14%. But here's the kicker: this effect was only observed in people who were vitamin D deficient at baseline. In other words, vitamin D is not a performance enhancer, it's a deficiency corrector. This distinction is critical. Another meta-analysis in Osteoporosis International examined the effect of vitamin D on muscle strength and function. They found a modest but significant improvement in proximal muscle strength, particularly in the legs, among older adults who received vitamin D supplementation, again, primarily in those who were deficient at the start. So what mechanisms might explain this? First, vitamin D modulates intracellular calcium signaling in muscle fibers. Proper calcium flux is essential for muscle contraction. When you move your leg, your brain sends a signal down a motor neuron, triggering calcium release in the muscle cell, allowing actin and myosin to bind and generate force. If vitamin D levels are low, this entire process is impaired. Second, vitamin D influences gene expression via its nuclear receptor. Once bound to VDR, vitamin D can upregulate or downregulate a host of genes involved in muscle repair, mitochondrial biogenesis, and inflammation control. There's evidence, for instance, that vitamin D can enhance the expression of PGC1-alpha, a master regulator of mitochondrial function, which is essential for endurance and recovery. Third, and more subtly, vitamin D plays a role in insulin sensitivity and glucose transport into muscle cells. In older adults, particularly those with early insulin resistance or prediabetes, this can be a game changer. A muscle that cannot efficiently take up glucose will fatigue faster, recover slower, and hypertrophy less. There's preliminary evidence suggesting that vitamin D repletion can improve glucose uptake in skeletal muscle, thereby enhancing energy availability during movement. Let's also talk about balance and proprioception, often overlooked aspects of leg strength. It's not enough to have strong quadriceps, you need to coordinate those contractions appropriately through sensory feedback and motor planning. Vitamin D receptors are expressed not just in skeletal muscle, but also in neurons, including those involved in proprioceptive feedback and balance control. Several studies have noted improvements in postural stability and sway metrics following vitamin D repletion in older individuals. Now, let's get practical. What should your serum level be? This is where the science becomes a bit muddy. Different institutions set different cutoffs. The Endocrine Society considers deficiency to be below 20 ng/ml, insufficiency 2129 ng/ml, and sufficiency 3100 ng/ml. In my clinical practice, and based on a careful reading of the literature, I've found the optimal functional range for older adults seeking to preserve musculoskeletal health to be between 40 and 60 ng/ml. Above 60 ng, we start to see diminishing returns and, in some cases, increased risk for vascular calcification or other adverse effects, particularly if vitamin K2 and magnesium are not concurrently optimized, which I'll discuss in other sections. How do you get there? For most older adults, especially those living in northern latitudes or spending limited time outdoors, sun exposure alone is insufficient. The ability to synthesize vitamin D through UVB exposure declines with age due to thinning of the skin and reduced 7-dehydrocholesterol levels. Translation: if you're over 60, even spending time in the sun might not raise your vitamin D significantly. Supplementation then becomes necessary for many. Typical starting doses are 2,000 IU to 4,000 IU per day, with higher doses occasionally used under supervision to correct a known deficiency. Test, don't guess. 25-OHD is an inexpensive and reliable lab test, and I recommend checking levels twice per year, especially in winter when levels often drop. One caution here: vitamin D is fat-soluble, meaning it accumulates in the body. Unlike water-soluble vitamins that you excrete in urine, excess vitamin D can lead to hypercalcemia, which presents as fatigue, confusion, kidney stones, and ironically muscle weakness. This typically doesn't occur until you exceed 10,000 IU day chronically, but individual sensitivity varies. Always monitor calcium levels and kidney function if you're supplementing aggressively. Also important, cofactors matter. If you're supplementing with vitamin D, you need to ensure adequate magnesium, which is required for the conversion of vitamin D into its active forms. Roughly 50% of U.S. adults are magnesium deficient, which may blunt the effects of vitamin D supplementation. What about dietary sources? Fatty fish like salmon, sardines, and mackerel contain meaningful amounts of vitamin D, as do egg yolks and liver. However, relying on food alone is usually insufficient to maintain optimal serum levels, especially in older populations. Fortified foods like milk or cereals contribute small amounts but are not a reliable primary source. Let me close this section with a clinical example. A 72-year-old patient of mine, Frank, came in complaining of worsening balance, subtle leg weakness, and increasing fatigue during his daily walks. No new medications, no major changes in his life. After ruling out neurological causes and evaluating his musculoskeletal function, we did a blood panel. His 25-OHD level was 12 nanol-GML, profoundly deficient. We started him on 4,000 IU day of vitamin D3, paired with 200 mg of K2-MK7, 300 mg of magnesium glycinate, and a renewed emphasis on strength training. Within 2 months, his serum level reached 46 nanol-GML, and energy improved, walking time increased, and his self-reported balance and confidence during movement returned. Did vitamin D alone do this? No. Biology is rarely that linear, but correcting the deficiency enabled his body to respond more effectively to training, improved neuromuscular signaling, and helped resolve an otherwise vague constellation of symptoms. So when we talk about maintaining or even regaining leg strength in our later decades, we must acknowledge that vitamin D status is not optional, it's fundamental, not as a silver bullet, but as a baseline requirement to enable everything else from protein metabolism to neuromuscular coordination to work properly. Think of vitamin D not as a muscle supplement, but as a license to adapt. Without it, the body can't respond to effort, repair damage, or grow stronger. And in a population where falls, fractures, and frailty are common, that's a risk we cannot afford to ignore. If vitamin D is the architect of calcium regulation in the body, then vitamin K2 is the project manager, ensuring that the calcium ends up in the right place, at the right time, for the right purpose. And for people over the age of 60 who are actively trying to maintain or improve leg strength, this distinction is not just academic, it's clinically essential. The older we get, the more susceptible we are to two competing and seemingly paradoxical problems: osteopenia or osteoporosis, bones becoming weaker and less dense, and vascular calcification, arteries becoming harder and more rigid due to calcium buildup in the vascular wall. These may seem like unrelated issues, but they're not. They are, in fact, different expressions of the same underlying failure of calcium management. And this is where vitamin K2 enters the picture. Let's start by dispelling some confusion. Vitamin K1 and K2 are not interchangeable. Vitamin K1, phylloquinone, is found in leafy greens and plays a role in blood clotting. That's important, but it's not what we're focused on here. Vitamin K2, menaquinone, exists in several forms: MK4, MK7, MK9, etc. And these are the forms that exert influence on bone metabolism, vascular health, and indirectly, skeletal muscle performance. The mechanism of action is elegant and powerful. Vitamin K2 is required for the activation through a process called gamma carboxylation of several key proteins: osteocalcin, which is produced by osteoblasts, bone-building cells, binds calcium and incorporates it into bone tissue. Without vitamin K2, osteocalcin remains inactive and cannot do its job. Result: you may absorb more calcium via vitamin D, but it won't be deposited in bone efficiently. Matrix GLA protein MGP, found in the walls of arteries, acts as a calcium binding inhibitor. In other words, it prevents calcium from depositing in soft tissues. Again, without adequate vitamin K2, this protein remains inactive. Result: increased risk of arterial stiffness, coronary artery calcification, and reduced vascular elasticity, all things we definitely don't want in older adults trying to stay mobile. So what happens when you're deficient in K2 and supplement with vitamin D? You essentially increase calcium absorption, but lack the ability to properly allocate it. It's like having a construction crew dump building materials at your site, but no foreman to tell them where to place the bricks. Over time, this can lead to a paradoxical worsening of both bone and cardiovascular health. Stronger absorption, but poorer distribution. Now, what does this have to do with leg strength? Quite a bit. Let's connect the dots. Bone strength is a prerequisite for muscular performance. No amount of muscle power will compensate for brittle bones. A strong quadriceps contraction can be dangerous if the underlying femur is weak. Vitamin K2 enhances bone mineral density (BMD) by ensuring that calcium is integrated into the bone matrix where it belongs. Arterial flexibility is essential for blood flow. Muscles need blood to function for oxygen delivery, nutrient transport, waste removal. As arteries calcify and stiffen, perfusion to skeletal muscle declines, leading to earlier fatigue, impaired recovery, and poor adaptation to training stimuli. Reduced calcification supports better neuromuscular function. There's emerging evidence that vascular health is linked to nerve function, and nerve function in turn controls muscle activation. A more supple vascular system supports better systemic homeostasis, and in older adults that may mean better coordination, balance, and strength output. Let's move from theory to evidence. A 2013 study published in Thrombosis and Hemostasis demonstrated that low vitamin K2 intake was associated with increased arterial stiffness even in relatively healthy individuals. More notably, the Rotterdam study, one of the most well-known long-term population studies, showed that those with the highest K2 intake had a 50% lower risk of arterial calcification and cardiovascular death. In the realm of bone health, a 2014 meta-analysis in Osteoporosis International reviewed 19 randomized controlled trials and concluded that vitamin K2 supplementation significantly improved bone mineral density and reduced vertebral fractures, especially in postmenopausal women. Interestingly, studies from Japan, where natto, a fermented soybean product rich in MK7, is consumed regularly, show significantly lower rates of hip fracture and higher BMD scores compared to Western populations, which may correlate with higher K2 intake. So how much vitamin K2 should you take? That depends on the form. MK4 is typically used in doses of 45 milligrams day, while MK7, due to its longer half-life and better bioavailability, is effective at 90 to 180 milligrams day. MK7 is my preferred form in clinical practice for general musculoskeletal support, unless there is a specific reason to use MK4. Osteoporosis treatment in Japan uses pharmacologic doses of MK4. It's worth noting that K2 is fat-soluble, and like vitamin D, it should be taken with a meal that contains fat to maximize absorption. There is no known toxicity associated with high intakes of K2, even in pharmacologic doses, but that doesn't mean you should megadose blindly. Balance and synergy matter. What about diet? K2 is relatively rare in the Western diet. Fermented foods, particularly natto, are rich in MK7. Some cheeses, especially aged hard cheeses like Gouda and Edam, contain modest amounts. Egg yolks and liver offer small contributions, primarily in the form of MK4. For most people, supplementation is necessary to achieve therapeutic levels. Now let's address a common question I get from patients. If I'm taking vitamin D, do I really need K2? The short answer is yes, especially if you're over 60 and aiming to improve leg strength, bone density, and vascular health simultaneously. Vitamin D increases calcium absorption from the gut. Without K2, that calcium has a higher chance of ending up in places you don't want it, namely your arteries, joints, and kidneys. In fact, in one study published in the Journal of Clinical Nutrition, researchers found that participants supplementing with vitamin D and calcium who were also taking K2 showed significantly less arterial calcification over time than those taking D and calcium alone. That's a critical finding for anyone using D3 to support muscle and bone health. Let me give you an example. A 67-year-old female patient of mine, active, relatively healthy, but dealing with mild osteopenia and intermittent leg fatigue, had been taking vitamin D3 5,000 IU day for several years without any K2. Her serum 25-DOHD was solid 52 neng-dir-ml, but she showed early signs of vascular stiffness on pulse wave velocity testing and was starting to report aching in her knees after walking. We added 180 mg of MK7 daily plus a magnesium supplement and retested her vascular markers 6 months later. Her arterial compliance improved by 11% and her joint discomfort resolved. Now, this isn't magic, it's biochemistry working the way it's supposed to when all the components are in place. So to summarize, vitamin K2 is essential for proper calcium allocation into bone, not arteries. It supports bone mineralization, reducing fracture risk. It prevents vascular calcification, improving blood flow to the legs. It works synergistically with vitamin D and magnesium. You need all three. For older adults pursuing stronger, more functional legs, this isn't a nice to have. It's a fundamental pillar of the strategy, because strength is not just about the muscle, it's about the entire system that supports it: bone, blood supply, and cellular metabolism. Think of K2 not as a supplement, but as a precision tool, one that ensures all the hard-earned inputs from diet, training, and vitamin D are directed exactly where they need to go. When you ask most clinicians about the impact of vitamin B12 deficiency, you'll hear terms like macrocytic anemia, fatigue, or neuropathy. And while those are indeed manifestations of low B12, they only scratch the surface. For anyone over the age of 60 who is concerned with leg strength, balance, and the ability to move through the world with power and stability, B12 status is a foundational, non-negotiable variable, one that is too often missed in routine screening. Let's start with a basic fact. B12, also known as cobalamin, is not just about red blood cell production. It's deeply involved in neurological function, methylation, DNA synthesis, and myelin formation, all of which play essential roles in maintaining muscle coordination, motor neuron integrity, and central nervous system efficiency. And without these, it doesn't matter how strong your muscle fibers are, the signal to activate them becomes impaired. And that signal from brain to nerve to muscle is especially critical in the legs, where strength, balance, and proprioception are continually integrated in real time as we walk, rise from a chair, or stabilize ourselves after tripping over a curb. Vitamin B12 is quite literally one of the key enablers of this neuromuscular system. Now, how does B12 do this? Let's go deeper. The human nervous system requires B12 for two main enzymatic reactions. Methionine synthase, which converts homocysteine to methionine, a critical step in methylation. This affects everything from DNA repair to neurotransmitter production. Elevated homocysteine, a marker of B12 deficiency, is neurotoxic, pro-inflammatory, and directly linked to impaired cognitive and muscular performance. Methylmalonyl-CoA mutase, which is necessary for the conversion of methylmalonyl-CoA to succinyl-CoA in the mitochondria. When this doesn't happen efficiently, methylmalononic acid MMA accumulates, and this is toxic to neurons, especially long axons in the spinal cord and peripheral nerves. Translation: without enough B12, the insulation of your nerves' myelin sheath starts to degrade, nerve conduction velocity slows, and muscle activation, particularly in the legs, becomes weaker, delayed, and poorly coordinated. This isn't subtle. A landmark study in neurology found that subclinical B12 deficiency in older adults was associated with impaired gait and balance even before overt neurological symptoms appeared. And another trial published in the Journal of the American Geriatric Society showed that older adults with low B12 levels had poorer performance on timed walking and sit-to-stand tests, even when adjusting for age, comorbidities, and muscle mass. Let me pause and emphasize this. Leg strength is not just about muscle tissue, it's about signal fidelity. If the nerves controlling your legs are impaired even slightly, you will experience decreased strength output, slower reaction times, and reduced endurance. Vitamin B12 is essential to preserving that neural integrity. But there's another angle: mitochondrial function. B12 is intimately involved in mitochondrial metabolism, specifically within the Krebs cycle, where it helps generate succinyl-CoA, a precursor for ATP production. This means that B12 deficiency doesn't just impair signal conduction, it reduces your muscle's ability to generate energy. In older adults, where mitochondrial efficiency is already declining, this creates a double hit: poorer muscle activation and reduced endurance within the muscle itself. Now, consider this. B12 deficiency is alarmingly common in older adults, particularly those over 60. The reasons are multifactorial. Reduced stomach acid. Hypochlorhydria impairs the release of B12 from food. Atrophic gastritis, a thinning of the stomach lining, reduces intrinsic factor, the glycoprotein necessary for B12 absorption in the ileum. Common medications like proton pump inhibitors, PPIs, and metformin further reduce B12 absorption. Vegetarian and vegan diets are devoid of natural B12 sources unless fortified. As a result, up to 20% of adults over 60 are estimated to have subclinical or overt B12 deficiency, many without realizing it. And because symptoms can be subtle at first, fatigue, numbness, reduced walking speed, they're often dismissed as normal aging. But they're not normal, they're correctable. So what should we measure? The standard serum B12 test is not enough. Why? Because serum B12 can appear normal even when functional deficiency exists. A better approach includes serum B12, methylmalonic acid, MMA, more specific, homocysteine, elevated in B12 and folate deficiency, holotranscobalamin, if available, the active B12 fraction. In my practice, I consider B12 levels below 400 pg/ml suspicious, especially if MMA or homocysteine are elevated. Functional issues with gait, cognition, or fatigue further increase the index of suspicion. How do we replete it? That depends on the cause. For patients with poor dietary intake but intact absorption, oral methylcobalamin at doses of 1,000 to 2,000 mg a day is usually effective. This form is bioavailable and supports methylation pathways directly. For patients with absorption issues due to atrophic gastritis, autoimmune pernicious anemia, or chronic PPI use, injections are often required. A typical loading regimen might include a 1,000 ml intramuscularly weekly for 4 weeks, followed by monthly maintenance. Sublingual forms are also available and may bypass some absorption barriers, though the evidence is mixed. The key is follow-up testing, recheck levels, including MMA and homocysteine, after 8-12 weeks to confirm biochemical correction and symptomatic improvement. Now, let me ground this with a clinical example. Ron, a 74-year-old retired pilot, came to me complaining of leg heaviness and occasional balance issues. He'd noticed he was walking slower and struggling more with stairs, even though his strength training routine hadn't changed. His primary care provider had tested his serum B12. It was 310 pgu, technically normal, but just barely. We ran additional labs. His MMA was elevated at 308 mol/L, normal 270, and homocysteine was 17 millimol/L. He also had a history of long-term PPI use for GERD. We initiated 1,000 Maligay methylcobalamin IM weekly for 6 weeks, then switched to sublingual for maintenance. Within 2 months, his energy had improved, his walking speed increased by 20% on repeat gait testing, and most importantly, he reported renewed confidence in his balance, no more fear of falling when out hiking. This wasn't placebo, this was reversing a biochemical bottleneck that was impairing neural signaling and muscle activation. So to summarize, vitamin B12 is essential for neuromuscular performance, especially in the legs. It supports myelin integrity, mitochondrial energy production, and neurotransmitter synthesis. Deficiency is common after age 60, often subtle, and frequently missed. Testing should include MMA and homocysteine, not just serum B12. Repletion improves muscle coordination, energy, gait, and balance, all critical for leg strength. In a world focused on macros, supplements, and exercise programs, B12 is a quiet but crucial factor that too often gets left out of the conversation. But if you're over 60 and serious about preserving strength, mobility, and independence, this is one biomarker you can't afford to ignore. Because at the end of the day, strength isn't just about muscle, it's about the system that powers and controls it. And B12 is one of the system's most essential keys. To wrap this up, I want to emphasize these vitamins support the foundation of muscle strength, but they are not a replacement for the hard work of resistance training, protein optimization, and sleep. Think of it like this: vitamin D gives your muscles the raw material. Vitamin K2 helps direct that material to build strong bones. Vitamin B12 ensures the electrical wiring your nerves are functioning at full capacity. Combined with smart training, particularly eccentric strength work, balance training, and protein intake north of 1.6 g day, you can absolutely improve leg strength well into your 70s and beyond. Remember, strength is not a luxury at this age, it's a requirement for independence. Thanks for listening, and stay strong.